A little bit of news, Wayne Feng became the latest member of the department to be recognized as a fellow of the American Academy of Neurology. Congrats, Wayne. A brief back, 1986, I was, I think, an intern at MGH. Duke breaks ground on the Joseph Bryan building, where neuroscience and Alzheimer's. Well, I don't think any of the folks in this room know who Ann Landers was, but she was, you would write her questions and send her a mail, and she would answer it in like the New York Times, and she was syndicated. Usually it was about your love life or you hated your husband or something like that. Lisa Hobson-Webb was the senior author of a new study looking at the insights, diagnosis, treatment of carpal tunnel syndrome in the Lancet Neurology. I actually think I'm going to read that one. Yang Chen was the senior author of a study that looked at the TRPV4 channel and trigeminal neuralgia. Marguerite Getz was a part of a study examining association of anxiety, depression, and cardiovascular health metrics in young adults. I think she can look at older adults too, because since I've been down here, I'm on 4 blood pressure medicines and Xarelto. So Wayne Feng was part of a new narrative looking at photoacoustic imaging to monitor cerebral blood vessel impairment after stroke. That was a mouthful. Anyway, back to the fun. The Christmas party was great. I want to thank Maria, Pam, Will, Megan, Dr. Seuss, Ornette, and Ann for setting up both the one at the JB Duke and the one on the second floor of the Bryant building. And there are a set of photos that are available that Will sent out to everybody. So take a look at them. We all know we're in the holiday season. Today's the 4th day of Hanukkah. Yalda, which is the Iranian festival marking the longest night of the year. Is that today? Is this day the longest day? Okay. The shortest light. Christmas is this Sunday, and Kwanzaa begins on the 26th until January 1. This is the final grand rounds of 2022. Will sent a very nice thank you. We won't be having grand rounds next week, but we will resume the week after that in Duke North. We think we have enough confidence in our Zooming abilities to go back there. Again, this is the CME, and today's presentation is part of our training the teachers. Let me handle this, Suma. No, she has to come here. There are rules. Okay, what happened with the Suma Shah? I did too. Okay, let's do it again. Reader view. I can do your slides if you want.
Happy to do it. All right, everyone, good morning, and thank you for having me start off this year's educational openers for our grand rounds. If this title looks lofty to anyone, it's because it is. I'm going to talk through some tools to maximize our learning experience. Next slide. So like any good academic, I'm going to start by referencing Adam Grant, but like any good millennial, this is from his Twitter account. So if this doesn't look familiar to you all, this is, I thought, a really eye-opening hierarchy of thinking. And to be a good learner, which is for all of us in the room, faculty, trainees, students, what have you, there needs to be a certain level of self-awareness. So I thought it was sort of humorous the way that Adam Grant presented this hierarchy, where the cult leader is at the bottom, who's someone who doesn't accept anyone else's thoughts, just their own as gospel. And that hierarchy goes up slowly from thinks they are correct, but also the other side, the contrarian, who only sees flaws in other people's logic and arguments, but also thinks that they are right. And then finally, where I think the most of us land, which is in the critical thinker space, these are the folks that think critically. They know how to approach information, appraise it, look for resources on how to better their thinking. Next slide. But that's what the next few minutes will be on, is that very tip of the pinnacle of this pyramid, which is the learner. And how do we think about becoming better learners? And truthfully, it seems like to level up, according to Adam Grant, from the critical thinker to the learner, not only do you not need to know where to look for resources and how to establish your foundation of knowledge, but also be surrounded by, which is something that's not always in your control, but surrounded by people who challenge your beliefs and present you new information to think through what you already know and maybe reevaluate and come to a newer conclusion. And I think when done right, this is the goal. This is academia. And though many of us may live in that level of critical thinker, being able to transcend to that pinnacle of becoming the learner and being able to cement new information, that would be the way to maximize the learning experience. Next slide. So what I've done in the next few slides is kind of thrown up there a few ideas that I've come across through various resources and sort of placed it into a 3-step learning strategy. And so step 1, which is the basics, is getting to the right place, knowing your resources, setting your own foundation so that when you are approached with information that is not your usual or that is not known to you, you know how to think about it and how to appraise it and whether or not it fits in. And then identifying your learning type, which to maximize how you learn, that self-reflection and that ability, something went away. Okay, excellent. I will identifying your learning type. To maximize your ability to be a learner, you need to know what works best for you. And what that might mean reading words on paper, which is many people. It also might mean listening to things such as podcasts or lectures. It may mean watching things like your faculty members and seeing how they do things. But being aware of how you learn, akin to that metacognition that Dr. Hernandez spoke about in his Educate the Educator lecture, is a first step to being able to do this right. Next slide, please. All right, so then part 2 is setting expectations. If you're showing up as a learner and if you want to transcend from being critical thinker to becoming a learner, you have to look for learning in unexpected ways. And that means there's a little bit of active work on the part of the learner. When you're faced with this information that might be a challenge to you, you may not know it. And so what this means, and I'll share some examples, is learning may not always look the same. It means that it's not always someone who stands up in front of a room and gives a lecture with PowerPoint slides or sends out articles after rounds. In seeing patients in clinic, it may be the way that a faculty member or colleague leans into the patient and turns away from the screen and really takes in the information. It may be that question that's asked after rounding at bedside by a faculty member to the resident or trainee or student that asks for something a little deeper about what was just seen in the room. Learning doesn't always have to look the same, and knowing where it might be occurring or being open to seeing it in different ways may help maximize that experience. And then let's see if I can do this right. Nope, went the wrong way. All right, and then finally, to cement the learning, the last step in this overview is introspection, self-reflection. One of the earliest pieces of advice I received as a medical student was to journal or to think through the patients that I had seen to help really learn from them. And learning doesn't just happen from patients. So if that means you speak to your partner at the end of the day or debrief with colleagues that sign out, think through how you approach the patient and then look it up later on PubMed or UpToDate. There are different ways to help self-reflect that will help reground you to the information you gathered, the information you knew, and what you have learned. So, in summary, let's see if I can get there. There are resources, and I'm just going to breeze through these so that you all know that they exist and that you know of us and the Duke Neurology Educators Academy as a place to turn to if you wanted to hear more about it. There are journals, as we mentioned, for those who like reading as a learning type. And Neurology Education is just on its second volume of its first issue, coming up with new curriculum innovations and presenting it to those in neurology. There are podcasts, though these are primarily internal medicine oriented. They're fantastic ways, and there are entire subsegments that are devoted to how to become a better teacher, educator, and learner. And then finally, of course, there are in-person conferences. And if for those of you who are interested in bettering yourselves as learners and educators, I would recommend the subspecialty conferences or the AAN education section meetings. And then at Duke, there's our Neurology Educators Academy, as well as Duke Ahead. And if you want more information about any of these things, please do feel free to reach out or email me.
And I will.
Thank you very much.
And
Yeah.
Can I email your slides to?
Absolutely.
Thank you. That's great. Fantastic. Very nice. So again, Will's going to put the CME in the chat, but that's it. Today's Grand Round speaker is Dr. Klaus Werner. He's an assistant professor of child neurology at Duke. Klaus got his M.D. from the University of Bonn and a PhD from the University of London. Did his residency at King's College, and then his pediatrics fellowship at Lister Hospital and Stevenage, England. He is an expert on both tuberous sclerosis and childhood headaches. He has had a clinic at Duke at tuberous sclerosis long enough so that he now wants to come to Maureen Road to start following his patients as adults. And we're just trying to find a way to make that happen because he's a wonderful human being, and in addition to being a great doctor and a scientist, and we're thrilled to have him here today.
That's what we're turning over.
Yeah, I got to do share screen again. Oh, so you could sit here. I can do this.
Would you mind doing your slides? Is that all right?
Happy to do it. Happy to do it.
Perfect. Thank you so much.
And we'll just get back into the share screen.
But the training, Stevenage was just a locum. I did in London and Cambridge and in pediatrics, and then child neurology at Hospital for Sick Children in Toronto. But that's thank you. Let's come to the talk, which is far more important. Now, as you know, I've started the tuberous sclerosis program about 6 years ago, and now we're finally getting there. Getting the attention, and hopefully, as you just mentioned, getting an adult clinic for an urgent needed adult clinic for adult patients. So the talk today is precision medicine using the mTOR signaling pathway in the tuberous sclerosis complex. Please, if you would, the next slide, please. This is our new logo. The Duke anchor with compassion, expertise, and research. And the next slide, please. And my disclosures, so I earn a little pocket money by speaking for Novartis and Noble Pharma. One is for Everolimus and the other one is for Sirolimus for the face. And today's objectives are to recognize common clinical features of tuberous sclerosis, discuss the genetic path, the basis of TSC in the mTOR signaling pathway, and then to summarize recent development of mTOR inhibitors of TSC, just like a story, not the Christmas story, but the story of TSC, how it was evolving. And next, please. So what is actually precision medicine? What do we understand by this concept? It's a treatment based on a specific molecular mechanism of a given genetic disorder. And it has the potential not just to modify the cause of the disease, not just to alleviate the symptoms, and that's the beauty of it. Can the TSC complex serve as a prototype for other genetic diseases? We'll answer the question at the end of the talk. So This is, of course, a German guy. How would I have to start with a German gentleman? This was actually the first description, and we know Recklinghausen for NF1 neurofibromatosis. He described, put my glasses back on, 1862, a little baby. It's died very shortly after being born, and he noticed a lot of myomata within the heart, and then a great number of sclerosis. He described them, and this was written down. It's a nice something to read if you have time. And the Berlin Obstetrical Society. Next slide, please. Oops, somebody is here. And this was then followed by our friends, the French, by Bernville. Hopefully I pronounce it correctly. All right. This is, oh, this is gone. This is forward. Beg your pardon, sorry. And he thought skin lesions were a coincidental finding, but then he described brain pathology and called it the term tuberous sclerosis of cerebral convolutions, convolution in French. This is this gentleman. Now, what is tuberous sclerosis in a snapshot? I mean, how are you there? I didn't recognize it. It's most of us hopefully know what tuberous sclerosis is, but I summarize it. It's autosomal dominant, inherited, very high frequency of spontaneous mutations, prevalence 1 in 6,000. It affects multiple organs. I've written them all down in case I forget them. The brain, the eyes, the heart, the kidneys, the skin, the nails, the gut, I beg your pardon, the gut. So anything can be involved. And the longer I work with adult patients, the more I see the gut involved. 2 genes, tuberous sclerosis type 1 and type 2, and the 2 gene products form a functional heterodimer, and this complex then inhibits the mTOR complex. And precision therapy is now. Now, what side? I'm going to point to. What is this on the left side where the hands are showing? A baby. Very good. As a baby. Perfect. What do we see with the hands? It looks like an ultrasound scan, doesn't it? That's the how we screen. These are the little cardiac rhabdomyoma in utero. You see this little heart? You see where the hands are. That's where the hands are. These are, yeah, that's where the tumors are sitting. This little thing there, that's a cardiac rhabdomyoma. Yep. That was no. This little blob there, this white blob, that's a cardiac rhabdomyoma. And then you go to the right side. That's probably bit more easy to recognize what that is. We believe that's a brain, right? Looks like a brain. And you see this big lump in there. That's a fetal SEGA. Exact. It's a SEGA, the big tumors you have in tuberous sclerosis. And actually, in some centers, or the discussion is depending how big they are, actually give the mother to get to the baby Everolimus, but we can discuss that later. So that's how we screen, that's how we pick them up, and the sensitivity of 90%. Next one. So what are these findings? What do you see on the left? Come on. Spots, yeah. It's not no, it's not the one we normally treat. It's not acne, otherwise I wouldn't be showing you this slide. So this is the classical angiofibroma, right? Raised, that's correct. But this is a mild picture. I've got adults with severe angiofibromas. The next one is a classical, that's why you need to look and examine the patient. Angiofibromas, and adults have them, if you look carefully, or the splitting of fingernails. The next one on the right, what's this? That's ophthalmology, classical. Retinal Marlborough hamartoma, classical picture. Then you go further down. This is the raised orange peel. Perfect. What's going on? Big brownie. The next one. Yes, ash leaf macule. Ash leaf. And what's the next one? We have 2 adults with that. This is congenital hypertrophy of the renal pigment epithelium. We have 2 of these in our department. Rare, but you see it. Faculty? No, faculty, they wouldn't be sitting here. Wouldn't be sitting here. Now, what is this? it should be coming out. I don't know why it doesn't. Genital over, you see that this overgrows up there? And animal pitting, you see the pitting with the pitting here? Exactly. So you need to look at the T's. So it involves really every organ. That's the problem. It's not just seizures, but as you will go through the talk, you'll notice that. What is this on the left side? Classical. No, on the left, this is a big kidney on the left side, right? You have the big AMLs, that's where the arrows are showing. Angiomyolipoma of the kidney. These ones, these big things here. Angiomyolipomas here. And you see on the right side, a cardiac rhabdomyoma. But they always get better, they regress. And then go further down. That's a long name. That's for the ladies. That's why you have every woman above 18 needs a CT to check is there LAM involved, lymph angiomyolipoma. Oh God, it's a long way. Lymph angiomyomatosis. These are the cysts. You can see very clearly there. These are the black areas, and they are also treatable. That's why you need to screen women. Otherwise, you miss it. It's all treatable. Next. Oh, I've got it here in my hand. Now, what is neurology? Manifestations of tuberous sclerosis. Epilepsy in a very high percentage of 90%. Yes, the intellectual disability is still about 60%. Autism is around 25%. We haven't changed that over the years, despite treatment. And then the subependymal giant cell astrocytoma, SEGAs. There's no surgeon in here, so I'm lucky. You will see in a moment why. This is a beautiful brain slice on the left hand. I like neuropathology. We should do it far more often to really see what we are treating. The blue arrows on the left side, you see the tuber sitting there. Can't you see them? You should be able to see them. And over there, the red one also is a tuber. On the right side, we have imaging. What do you call the classical picture on the right top? Candle gathering. I think that's what you call it. Is it candle gathering? That's the classical description. And again, further down, we have the tubers all shown by the red arrows.
Are those with contrast or not?
Without contrast.
They're that bright.
Yeah. Epilepsy due to tuberous sclerosis. Epilepsy is in more than 90% of our patients. About 30% are refractory, and most of the epileptologists can sing you a song about how refractory they become. About 2/3 in the first 2 years, present in the first 2 years. What's the most common presentation? The pediatric neurologists know that is infantile spasms. That's how they present in the first year of life, in about 40%. Successful cessation of anti-seizure drugs. If this is an old paper by Roach et al. No seizures for more than 3 years, normal cognition, and a brain with not many tubers, then you have a good chance of cessation the drugs. Surgery will benefit some patients, but you have to select them, and the question is, when do you start surgery? The current thinking is the earlier, the better to intervene. This is a classical picture of, on the left side, you see the huge lump in the MRI. This is the SEGA, a subependymal giant cell astrocytoma. And about 12% of people with tuberous sclerosis, typical, they're named because they're very, it's a bit, or very important, they arise before adulthood. That's why we screen, that's why we do all these MRIs for the kids. And now make the surgeons angry. I'm not angry, but I'm ahead. In the past, surgeons had to intervene and take it out. Now we melt them away. Melting them away with mTOR inhibitors. It's beautiful, and I'll show you later pictures. I've got several patients where the surgeon had to go in and take the tumor out, and you see still the big scar and where the tumor was sitting. No, that's not necessary. That's why we screen these patients properly so they don't fall through. I have two patients, I can say I have two patients where I did use it and there has no surgical intervention needed. So unraveling the genetics of tuberous sclerosis, the Fryer paper was among the first to link a specific disease to a specific non-X chromosome. This was also in London, and I spent, as you probably know, 15 years in London, and it was done in Bristol and the University College London. So brings me home, half home. And some multi-general tuberous sclerosis families were clearly not linked to chromosome 9. So then the search started for yet another chromosome for the second locus. And then the linkage of important gene locus tuberous sclerosis to polycystic kidney disease. Very often I have at least 4 patients. They're polycystic kidney disease.
She was here with Alan, right?
Yes, I thought you were going to get up. Yes, all right. Thank you for mentioning it. So, but
There's Alan Rosen too.
We have quite a few patients of adults and children where they're polycystic kidney disease and tuberous sclerosis. They're very difficult to treat. Unraveling the code, just the history again. First, 1987, the chromosome 9, followed then by 1992, type 2, chromosome 16. Then it was identified in 1993, the 16p33 according to tuberous sclerosis type 2, tuberine, the protein product, and then later hamartine was identified in 1997. And these tuberine and hamartine, they build a physical complex. In a summary, these are just what I just mentioned to you. They have a very high spontaneous mutation rate. Tuberous sclerosis type 2 is more frequent in new spontaneous cases, and 2 gene products building a dimer, and this inhibits the mTOR complex. And there's this striking, it's very incredible phenotypic variability. If you see what patients have, what they don't have, but this is unexplained by gene or by mutation type. So if anybody wants to join me in the TS clinic, it's fascinating, I think. Genotype versus phenotype. Okay, there's also very nice, this has been then replicated. This is an old paper, but still stands. They looked at 325 patients, and overall type 2 was far more common than type 1. Type 1 was more common in familial cases. Familial, and the severity with type 2 was much more severe than type 1, and more than in those when have tuberous sclerosis, but no mutation was identified. As you can see, the severity, this is NM1. And type 2, you have more renal cysts. If the protein has been truncated, then you have more facial angiofibromas and nail lesions, and missense mutation, more cerebral migration lines, and small hyperpigmented lesions. So why is this happening? How do you explain all this? What causes the phenotypic variation? Some features are age or sex related. The type 2 is, as I mentioned to you, is generally much worse than type 1, and possible via a second hit mutation to promote tumor formation, then possible via somatic germline mosaicism. And then there are the mTOR pathway is very complicated. There may be other components involved in that. And interesting, again, mentioned the word interesting, even if you have identical twins, they're often different when they have tuberous sclerosis. Is it inhibition of a mutated gene, or is it the epigenetic phenomena? So what do these genes do? Tuberine and hamartine, they build a complex. Hamartine is like a chaperone protein, prevents tuberine from clotting up, from clumping together. Type 1, a complex, type TSC1T complex inhibits the mTOR via a G protein, RABE. I'm sure you've heard of that. Mutation of either gene increases then the mTOR activity. Mutation of either gene, that means the gatekeepers are gone. If the gatekeepers are deleted or not present, then you're always on the gas pedal in the car, or the mTOR activity is always present. That's why I have all these alterations in any part of the body. The mTOR promotes ribosomal biosynthesis and protein translation by phosphorylating the S6 kinase and then 4E binding protein. The occurrence of mTOR type 1 and type 2 homologs broadly across species was then a very early indication of their importance, obviously, right?
So, Klaus, just for a second,
Sure.
why did you become interested in this?
I think you asked me that some time ago. I did it during my PhD. I've seen a lot of patients with and looked with ventilate potentials. And I found it fascinating how they responded with vigabatrin.
So your research was
Yes,
related.
yes, research related, yeah, absolutely. And then when I came, Mohammed asked me, Dr. Mikati asked me, hey, I'd like to build a TSC clinic. That also gave me then, yeah, the courage to fulfill my little dream, I call it. Now, beg your pardon. Then we also have pervasive effects. If you have a dysfunctioning mTOR complex, it antagonizes insulin signaling. It promotes tumor formation and cell growth, impairs cell differentiation. It disrupts neuronal migration, abnormal myelination, and alters angiogenesis. Okay, that's a cool one. I hope you're enjoying this. So,
We are.
what is the function?
You're very entertaining, so enthusiastic.
Yeah, because I like what I'm doing. So I think we all do, hopefully. Otherwise, if you can't share the joy what you do, why are you doing it? And they're very grateful, these patients, very grateful. If you listen, that's what you said earlier on. I picked that up. RAPE is a homolog of RAS GTPase in brain, and it's quiet, then it's inhibited by GDP. Okay, it's quiet, nothing seems to happen. But if it's initiated by the GTPase, what we mentioned earlier on, then it starts to initiate the mTOR cascade, starts to stimulate, right? Okay. So, and then leads to cell proliferation. It's very simplistic, of course, but it gives the message. Now, if you have the gatekeepers TC1 and TC2, everything's fine. There's control, all organs do what they're supposed to do. And there's an inhibition. You see, if you have TSC1, they inhibit the mTOR pathway if they're working. But what happens if either TSC1 or TSC2 are not working? If the inhibition, like in a car, and you continuously working, and that's in a very basic explanation what happens in tuberous sclerosis. But we're clever, or we're trying to be clever. We're using Everolimus and Sirolimus, which really have changed the picture of tuberous sclerosis. This is just, I have to read this off. This is just a far more complicated picture. You see in the middle, this yellow ball, the mTOR pathway, which is inhibited or altered by TS1 and TC2. You see this above. And then via these proteins, via the cascade, leads to a protein synthesis, which goes over to cell growth, proliferation, angiogenesis, cell mediation, and cell orientation. And this is stimulated by nutrition. You see this left up there, and growth factors. So it's a very, very complex cascade involving many, many proteins. But I gave you earlier on the basic mechanism. That's what I like you to remember, because that's very, very complicated, and most people don't remember all these proteins. Now, that's very cool. This was done by Franz et al. Cincinnati, Annals of Neurology. So about 10 patients, and he started, this is a SEGA. On the left side A, you see this little nubble sitting there in the ventricle. Yes, please, thank you so much. This is what is sitting. That's a SEGA, right? So if you let that grow, it will grow and will obstruct finally. And B is then after 2.5 months of treatment, it's gone. So you really melt them away. And then C, if you go to C, please. Thank you. Then he comes back when you stop this therapy. That's why when patients ask, hey, am I going to be on that forever? I said, yes, for a while. And otherwise, the mTOR cascade is going to start growing again. And then D is after for therapy for 8 months. Isn't that fascinating? The surgeon hasn't to go into our beautiful brain. Now, this rapamycin then has been shown also for renal angio. That's not spelling it correct. Renal angiomyolipoma. You see on the left side where the arrow is. You see this big chunk there. That's an AML, renal angiomyolipoma. And then on the left side, on the right side, please, above on the right side. Thank you so much. You see it's gone. It's getting much smaller. Do you see that? The size is, and now putting this all together, you see there are several patients on the left side. Obviously, you see the volume is much smaller. It's coming down. And if you know Everolimus on the right side, it's big. I've learned my lesson. I had a patient who didn't follow up with me, was seen then in a peripheral hospital, start to bleed, and they bleed like hell. Excuse my language. This is an emergency. When they start bleeding, it's not fun. And he continued to bleed, came then to us, and he had in the middle of the night here in Duke, was on the table and was the vessels were either coagulated or were clogged in order to help the bleeding. This is a true emergency when these bleed, and I have several ones in clinic which very large AMLs. This is the long word I couldn't spell earlier. Lymph angiomyomatosis in ladies. This is in the same study by Bisler, where these ladies were treated, and you see very clearly with sirolimus therapy or without therapy, the forced vital capacity or the forced expiratory volume V1, you see that is clearly, there's a difference. It's very easy to see. And if you don't treat them, they become very sick. And I have seen many, I can truly say adult patients here, they were in our system, but they haven't been looked at properly. So they're walking ducks. Now we're thinking about a new inhibitor, Everolimus. On the left side is a Rapamycin, this is what I mentioned. And on the right side is Everolimus, and they're just changed in the hydroxic change. This is the yellow circle you see. And again, mTOR mammalian target of Rapamycin. So the new mTOR inhibitor is more selective for the mTORC1. It's now approved by FDA for giant cell tumors and renal angiomyolipomas. Some studies of subjects, parents report fewer seizures and to improve cognition during trials. And other trials for non-TS related tumors for non-neoplastic complications for TSC. This was shown also by Franz et al. This is was published in the New York Journal of Medicine. The individual SEGA responses to Everolimus. You can see the bars. Each bar is a patient here, and you can see clearly how they are responding. And these are numbers are on the right side in the corner. Each patient responded. More than 30% reduction from baseline and more than 50% in 17 patients. So it's really a phenomenal response to this medication. So Everolimus-induced reduction in SEGA size. Baseline on the left side, you see this white tumor sitting in there. And then after 48 months, Everolimus on the right side. Then we had randomized clinical trial, frontier centers in 10 countries, enrolled 117 subjects, used everolimus to placebo, and primary endpoint was reduction of SEGA by 50%, and as everolimus response, and 35%, 27 out of 78, and placebo response was 0. Obviously, it doesn't do anything, but you had to show that. And the second randomized trial showed the same benefit for renal AMLs. That's why we treat these patients with everolimus. And very often we get patients, I receive referrals, they come from outside, nobody started it. You can really change a life if you start early and appropriately. And I'm happy to teach this in clinic if anybody's interested. Everolimus for epilepsy and cognition. That's a question always coming up. There are striking improvements in seizures and cognition while taking mTOR inhibitors. There were trials to evaluate its effect on epilepsy and cognition. There are 2 papers were saying it's not recommended for cognition. I don't agree there completely. I have several autistic patients. I started it, and mothers have come back to me, hey, Dr. Werner, my child is not the same. He's cracking jokes. He's more social. So I don't agree with that. But these are case studies, and I'm writing them up as we speak. Everolimus improved seizures enough for FDA indication. Everolimus did not modify cognitive function, but I don't agree with it, but that's generally the teaching currently. This is hot new. If you don't want to see a TS patient, please send it to me. I'll start treatment. Angiofibromas is now FDA approved with topical rapamycin. This was the new treatment at the International Congress in Dallas recently. So the facial lesion improved in trials for SEGA and renal tumors. And this shows that on the left side, you see clearly the angiofibroma, but that's mild still. And then the difference. Isn't that beautiful? A girl who's been picked on in school, that's how her face will change. So what about preemptive therapy? Many TSC neurological features are not neoplastic. EEG abnormalities often develop before clinical seizures. So we know that it has become a biomarker. And there's evidence for preclinical seizure treatment. Would early therapy prevent TSC manifestations from developing? You'll see it. Now, that's an interesting model, and I'm going to bring this in for certain reasons to convert you even more to show you the evidence. This is a knockout mice. It's a poor mouse having got no TSC1 gene, right? And you see, I've got to go up here. You see 100% of those controls, and those are lacking it, they're all dying, right? You can see that very clearly, right? And then if you use rapamycin or an analog RAD001, the survival goes up. You see day 80, they all survive. This is the bar 100%. And the other ones, the controls, are still dying. You can see the difference when you treat them properly. It's fascinating. We can really show it in a really nice mouse model. Poor mice, but it helps us. And the mTOR inhibition effect, then you also show that brain weight versus body weight in the mutant is very clearly different compared to the controls, and then treat with mutants plus rapamycin, control and rapamycin. You can see there clearly the difference, right? And also the cell size. The cells and mutants are very much larger in the brain when you look at the cortex. And when you treat them, they become normalized again. So it really has a phenomenal effect. And this is now a very beautiful picture showing the myelination. The control is here on the left side, beautiful myelin, the mutant in the middle, hardly anything, and then the mutant on the right side, plus rapamycin. It's phenomenal what's happening up there in our brain if you use the medication. So what about pre-symptomatic TSC treatment? There was a prospective study of 14, these were the Polish team of 14 patients with tuberous sclerosis, and they started vigabatrin.
Oh, yeah.
No, it's fine. It's fine.
Started vigabatrin. Now we've moved something. Oops. How will we get it back?
Okay.
Oops.
Seems to be zooming down.
Somewhere in the middle.
Let's see the share screen. Hold on.
No problem.
Shows you were hanging by a thread.
That's fine.
Yeah, you're still on the Zoom. There we go.
Oh, yeah, perfect. No worries. We get there. Teamwork.
It's good to
Uh,
practice today. Otherwise, Chris is gonna take us off the job again.
So these were the Polish group is Jubiak. They looked at 14 patients. In comparison, 14 patients with tuberous sclerosis who began vigabatrin after an abnormal EEG, but before they started having seizures. That's the difference. We normally wait until the fire is burning, until they have spasms or seizures, then we start. But they started when the EEG is changing, right? And they compared it with 25 patients, is a bigger number, of course, treated at the onset of clinical seizures when they had seizures. Then they started treatment. And they had a follow-up interval of about 12 years. And the preventive group, that's the group where they started treatment early, had a much higher IQ, had fewer people with intellectual disability, and fewer with moderate severe cognitive impairment. The only thing what hasn't changed was autism again. There should be 60, sorry about that, 60% should be moving over there. 20 had moderate to severe cognitive impairment of the treated group, 21% versus 60%, and had more people without epilepsy, 50% versus 5%. No. Here we are. And this was leading then to the European trial, the EPISTOP trial, with a multi-center trial, 9 European and 1 Australian, where they had 94 infants before seizure onset. And they did exactly this, but it just with bigger numbers, with monthly video EEG monitoring, and epileptic discharge before seizure onset in about 54 of 94 patients. And 25 out of 54 received vigabatrin before they had seizures. That means when the EEG is changing. That's why we do, when we have a new infant, I do every 6 weeks EEGs to see when it's changing. Fewer, and in this trial, fewer developed clinical seizures, 52 versus 84%, but it's clinically significant. Reduced risk of drug-resistant seizures, 28 versus 64. No patients develop infantile spasm. That's a huge message. And developmental delay at age 2, 25 versus 41% was not significant, but it's still a difference, but it was not significant. And again, the autism was not changed. So we're still missing something. So should we initiate mTOR inhibitor at diagnosis? That's the question everybody is asking currently. When should we start? Vigabatrin use in EPISTOP trial likely inhibits the mTOR. I mean, we know that it most likely does that. Clearly, seizures do better if you treat it early rather than waiting for the fire to burn. Would treatment with mTOR inhibitor at diagnosis mitigate other manifestations? Very valid question to ask. A trial is currently under the way at UNC. They're starting a trial with using sirolimus in the first 6 months of life. So the next challenge is for TSC, when should treatment begin? Pre-symptomatic anti-epileptic agents, early use of mTOR inhibitors, more effective mTOR inhibitors. Do mTOR inhibitors benefit conditions other than tuberous sclerosis? And the care of adults with TSC, I mentioned a few comments earlier, is a huge problem. And I'm trying very hard, and I'm glad you mentioned it early on, thank you, to really set up an adult clinic, because when they come to my clinic, they all say, hey, it's very beautiful to be here, but wouldn't it be nice to have a separate rooms for adults? So the take-home points are, tuberous sclerosis affects multiple organs and systems, and the phenotype varies tremendously. Type 1 and type 2 mutations yield similar phenotypes because gene products form a physical complex. TSC2 causes a more severe phenotype, so that's what you can, if a mother is asking you, doctor, where I'm going to be in several years, and depending on what the EEG is showing, and depending on tuber load, you can tell her, hey, it's very guarded what you say, but it's very likely to have a worse outcome than a type 2. Therapy with mTOR inhibitors mitigates some complications. Pre-symptomatic therapy may be useful for TSC-related epilepsy and potential for other manifestations. So are precision medicine therapy at least plausible for other genetic conditions? Yes. So thank you for parents and the team here. The only thing what I've forgotten to mention is what is also a huge problem for tuberous sclerosis parents, tuberous sclerosis associated neuropsychiatric disorders, and about 90%. This is present. They have depression, they have ADHD, autism. That's also where we have to work much, much harder to help these patients rather than treating only the seizures or the tumors. I hope this was educational for you guys for tuberous sclerosis. Thank you.
Thank you very, very much. If there's any questions in the room or on the internet, just put your name in the chat and we'll call on you.
Thank you for the talk. In terms of the mTOR inhibitor starting them early, are there any adverse effects that should be noted if that would prevent you from making hesitant?
Oh, sorry. It's a good question. As I mentioned, there's a trial going on, starting to use sirolimus in the first year of life to see if it really has any impact on cognition. I've used it in many infants. It's obviously not FDA approved, dual levels, and it's very well tolerated. But you need to tell them if the child gets a fever, becomes unwell, then you need to ask for help. The most common side effects of mTORs in adults and in children or even in little infants, when we put all the data together, are a mucositis. That's number one. You change the lipids, so you need to do a lipid profile beforehand. And then also you may get a pneumonia, but I haven't seen that. So the most common things are a lipid changing and the mucositis. And the big epilepsy trial has shown very clearly if you give the risk of mucositis is highest in the first 12 weeks. If you give dexamethasone mouthwash every day, you avoid that problem. So it's generally very safe in safe hands, but you need to do levels. And if the mother, that's what is also my own experience, if the mother doesn't do levels, I wouldn't give her everolimus because it's very dangerous. It can be dangerous because you don't know where you are.
Kevin Van Landingham, you had a question?
Yeah, thanks so much, Rich, and thanks for the great talk. Did the studies on the treatment with mTOR inhibitors that you presented control for TSC type 1 or 2? Or did they just take all comers? And if all comers, were the groups balanced?
Yes, they were balanced. There was type 1 and type 2, both were involved. Both were involved. But as I mentioned earlier on, you see the bigger tumors more with type 2. Bigger tumors, you have type 2 than type 1.
I think the more interesting data you presented was the improvement in cognition and function. I mean, especially in the patients with TSC2 that are profoundly affected without this treatment. So go ahead.
Sorry, I agree with you. There were two papers, I can send you an email, where they looked at cognition and say it's not indicated. But the question, then there came another paper that was saying, hey, are we not we're starting too late? If you have somebody who's 30 or 40 and is severely autistic, start then with everolimus. Are you surprised? No, you're not surprised. You have to start very, very early. And that's the current thinking in the tuberous sclerosis world, to intervene early in order to see, can I really rescue or before the neurons walk a different way or connect in a different way, and I can inhibit this by everolimus. It has been shown to alter the white matter very clearly. There's several papers in tuberous sclerosis patients, how it alters the white matter function and bringing the bundles together. It's a fascinating world, how much it really can change. But the question is when, and that's the question we have to answer.
So I don't know if anyone saw this, but there was an article in the New York Times in the last couple of days about a company that will make genetically engineered treatments for kids with genetic disorders that affect just 1 or 10 people, that they've now figured out how to do it, and they can make enough money on 1 or 10 people to make it worth their while. And I just wonder, are there any other potential targets that they're trying to develop for this besides directly inhibiting mTOR, like inhibiting some of the downstream signaling rather than just knocking back the entire thing?
It's a good question. They're trying to. There's some genetic studies with genetic mouse how we can replace the protein. That's what they're also doing in Boston. This is they're starting to doing that, but I don't know that there are any other ways of influencing this by different means, by different to the mTOR pathway. I'm not aware of that. No.
All right, Klaus. Thank you very much. Sorry a little bit for the
No
Zoom,
problem.
but it wasn't like bad Zoom. It was just a little crazy Zoom stuff going on. But your talk and your enthusiasm is remarkable.
So hopefully the message came over a bit.
Oh yes, and your enthusiasm
That's right.
for what you do as well.
Thank you. Thank you very much.